So we do all our myopic treatments wavefront optimized. If there's significant astigmatism, we look into the topography guided option. We do all our hyperopes topography guided, here mainly in order to correct for angle kappa, which is present in most hyperopes. And I'll spend just a few minutes talking about the Athens protocol, which is our signature procedure. We have introduced the combination of a partial topography guided normalization of irregular corneas that we find in keratoconus and post laser ectasia with high fluence collagen cross-linking. And you can see here an example of a 26-year-old lady. We'll turn onto the screen. So this is our treatment for a 26-year-old female that has advanced keratoconus, and you can see here that the treatment plan is a very irregular ablation. It is very hot in this area, which is the area of ectasia, but what's interesting is that there's a loop of hyperopic treatment away from the cone. And we'll show you over the next few steps how we derive to this treatment. This patient has a refraction of -3, -6.5, 6.5 diopters of astigmatism at 160 degrees. And with the help of my technician, Andreas, we're going to go and to our diagnostic. Now here we can look into all the design treatments, and we can design all these treatments on our laptop down where we see patients. We don't come into the surgical room to design treatments. You can see all the options. As I mentioned, we have the wavefront optimized, which probably is excellent for the majority of regular myopic patients. Then we have wavefront guided, which is a very fine tool to modulate potential wavefront aberrations, such as coma, etc. Then we have the topo-guided TCAT, which is basically a placido disc-based topography guided. We have the topo-guided Oculink, which is the pentacam-driven topo-guided. And then we have the custom Q. This is basically a wavefront optimized that we can further manipulate the asphericity. So we can manually increase the possibility of having an aspheric cornea after the treatment. And last is the PTK mode, which we use always in the Athens protocol patients in order to remove the epithelium. So we use for PTK 50 micron, 6.5 millimeter diameter PTK treatment in order to remove the epithelium, and then we go on to design treatments. So we're going to try and design here treatments with both the oculizer and the Oculink. We'll start with the oculizer, and remember, let's start with a topolizer. We'll start with a Vario topolizer. So you can see we obtain very reproducible maps, and what we'll do here is we'll try and look at the topographic astigmatic measurements. How close is the axis of the astigmatism? You may not be able to read this, but the axis of the astigmatism on this patient is extremely close. 152, 152, 151, 154, 152, and 152. So we're going to throw away the 154 because it's the only one that's slightly off, although these are identical numbers. So we'll throw off the exam 154, and now it's taken out of the equation, and we'll proceed with adjusting Q value to 0 because all keratoconic eyes have very high Q values, so we don't have to enhance Q value. This saves a little bit of tissue. This is the purpose of that. We'll go on to the next step where all of the data, and I'd like you to pay attention to this, all the pachymetry data on the cornea have been already placed onto the treatment plan based on the pentacam pachymetry maps. So this is done seamlessly, automatically. The exams were taken clinically in a different day in our patient evaluation area, and now we're assessing all these data. Remember, we're looking into the topolizer, so the topolizer does not have a pachymetry data, but the network knows what the pachymetry data are, and it's bringing in those data even in the topolizer mode. So we're adjusting now. This is the clinical refraction of the patient. We'll go on to the next step. And this is the treatment plan if we do the clinical refraction. Now, in order to understand what the topographer wants to do here, of course, we're going to make the optical zone smaller because we need to preserve tissue. We're going to try and zero the refractive components. So let's go to 0 on sphere and 0 on cylinder. So this way we'll see the attempt of the topographer to normalize this irregular cornea. So you can see what I mentioned before, that this is a partial myopic treatment over the cone, and there's a partial hyperopic treatment. This is a significant hyperopic treatment, and this is intrinsic for the proprietary Wavelight software, that it can create this hyperopic treatment in order to make this area here appear more elevated. So we're normalizing the cornea not by reducing the curvature of the cornea all around, but by reducing a little bit of the cone and elevating the area that's right next to the cone. So we can see that this treatment is about 35 microns. So we're going to try and correct some of the refractive error as well. The minimal thickness is 485. We're going to try and correct here 2 diopters of sphere. So we'll go to 2 diopters of sphere and see how the numbers change. And again, now we're treating some of that irregular astigmatism, and we'll try and do maybe 1 diopter of myopia. So from a refraction of -3.5, -6.5 at 160, we're treating only -1, -2 at 158, which is the topolizer axis of astigmatism. And again, the purpose here is to normalize the cornea and not necessarily to treat the refractive error. So this is a treatment that has derived from the topolizer. We'll go back now and look at the similar treatment that's derived through the pentacam. So we're going to go back to our treatment mode, and we'll look at the Oculink, same patient. So here we have 2 high definition pentacams. We'll proceed to the next step. Again,